The one of your earlier slides, kind of the endoscopic kind of sleeve that you make. So you had mentioned kind of the immediate pain, but what does it? I mean, this is just like, what does it feel like when that is done? You didn't talk about anything like long term. I mean, do you feel pain? Or is it less pain than if you had an actual surgery? But what is the actual sensation of digesting when you have that done endoscopically? Like, what should we tell? What do you tell your patients?
Yeah, no, that's a good question. In full disclosure, I don't do this procedure. My partner, Rabindra Watson, does. But, certainly immediately after the procedure, patients do have, significant symptoms. But it usually is managed aggressively with pain medications, PPIs, et cetera. But I think the main sensation is just kind of an increased sense of fullness, kind of like a Roux-en-Y, that you get full really easily. Things go through a little slower. But in general, I think patients go back to feeling, relatively normal within about 2 weeks. They are put on a liquid diet, usually for 2 weeks after the procedure, and then food is slowly increased after that.
Chris, I've got a question also about the gastric sleeve. Because are those sutures, can you cut them, and does that make it a reversible procedure in case it's needed?
Yeah, excellent question. Yeah, it is technically considered a reversible procedure, because sometimes when we're doing, I didn't touch on it, but when we do stomal closure, so for a Roux-en-Y patient who had their stoma opens up, we can suture that back down. Oftentimes for that, we'll ablate with APC first, so then it actually kind of sticks, essentially. So even if you cut it, it probably remains closed. But for this, well, there was APC marking. You're not ablating all of that. So it's not really, the tissue's not sticking and adhering together. So you can cut that. So it technically is a reversible procedure. Sometimes it can be challenging to do that because it's hard to get to those sutures.
It was an amazing presentation. Quick question is, any experience with the gastric balloon?
Yeah. Again, not personally. The gastric balloon has, it's been around for decades now, and it's kind of come and gone and had problems. And there's been a number of complications more recently, and I think that is really kind of going away. I think, again, I'm not an expert in obesity, but our group, at least personally, is not doing that because we don't believe as much in it as well. And I think the symptoms from it are pretty significant afterwards. The weight loss is not as impressive. And again, the complication rate at this point, I think, is unacceptably high.
To prevent post-ERCP pancreatitis, how many measures are you following? Are you giving them fluid and indomethacin and nitrates? Are you combining all of them, or just use one regimen versus the other?
Yeah, no, it's an excellent question. There's been data too that's kind of come back and forth on, in these the standard risk patients, do any of these interventions work? And many of them have actually shown that there's not much of a decrease because I think the rates are low. Our personal practice is, what is the risk of the intervention we're giving? And rectal indomethacin has a pretty low risk. So if someone doesn't have some, allergy to NSAIDs or some reason why they shouldn't be, certainly any high-risk patient, we're definitely giving it. And even in most native papillas, at least considering giving it, it's not a standard practice that we give it in every single person. But definitely in terms of patients who don't have a contraindication to get a lot of IV fluids, I definitely am using that because I think that there's very little downside to that. I tell the patient you're going to pee a lot after this procedure. So a lot of times, and then in high-risk patients, I'm doing both of those, rectal indomethacin and IV fluids, and then plus minus the PD stent. That's a more complicated one because, again, if you're trying to get in, maybe you increase your risk. But certainly if a wire does go into the pancreas, then oftentimes I will leave a PD stent in those cases. Or of course, high risk like ampulectomy. The data had been pretty limited before. So we are currently not using that. I'm not sure that this one study will change my management, but it certainly is intriguing that we have something else in our armamentarium. Now, do we need to do 4 different interventions? I think that's going to be overkill, you know. So again, it's not going to change my practice at this point, but it's certainly something we'll watch out and see if there's more data coming.
Since naproxen has a 12-hour half-life and can be taken 6 hours before an ERCP in a single dose with low morbidity, why is everyone fascinated with doing suppositories of these things when you could just give a single dose in your average or slightly high-risk patient 6 hours before? It wouldn't affect anesthesia, and now it's circulating before you trigger the ERCP rather than 15 to 30 minutes later when you finish the ERCP. Is there any logical reason why it can't be given orally?
Yeah, that's a good question. I admittedly don't know the answer to that one. I think it's just been the sort of the most studying, and it's an intervention that you can do in your unit right there, rather than arranging for the patient on their own to take it, you know, prior to the procedure. But it's probably a valid point.
All right, great.
Thank you.
Thanks, Chris.